Welcome back to PulmPEEPs, everyone. Furf and I are so excited to bring you a highly anticipated crossover event as we're joined today by Eddie and Todd, the co-founders of the ICU Ed and Todd-Cast. And knowing these two gentlemen, look forward to a great discussion today. Furf, how are you doing?
I'm doing good. I'm a little congested, a little under the weather today. I have a daycare virus that I'm dealing with, but I'm very excited to be here. And neither hail nor sleet nor rain would stop me. So I'm excited to still dive into our topic. For those of you listening on the Ed and Todd-Cast, Christina and I are the hosts of PulmPEEPs, an educational podcast about pulmonary and critical care, if you haven't heard us. And we're really excited to be podcasting again with Todd. Todd has been on the show before. He shared his wit and wisdom with us about sepsis and when we were at the chest conference. And we're really excited to be here with Eddie as well, so we can dive into a cool topic and a paper that they've both worked on. So we're really excited to be talking to you guys today.
Yeah, I also have a little bit of a daycare illness. I think my wife is on like day 35 of symptoms, she says.
Oh,
So,
good.
yeah, no, it's certainly great to be here. For the PulmPEEPers out there, like they said, Todd and I run the ICU Ed and Todd-Cast. We have a little bit of a more narrow focus. We focus mostly on ICU medicine, and we bring the latest and greatest in critical care medicine and research. And I think Todd said it the best when we were doing our live show, where how part of the way you get better in critical care medicine is keeping up with evidence and reading papers. And our podcast is helping you read that paper. So we'll go through the introduction and the methods and little design quirks and take you through the results and end up with what we think and how it impacts our practice.
Yeah, I'm happy to be here also. I will say my kids are 17 and 19, and I don't think you ever get out of the daycare virus problem. So don't think that just when your kid gets out of daycare, you no longer will have respiratory symptoms, because I think they're ubiquitous. But as Dave said, I've been on before, and I'm always happy to be a guest on PulmPEEPs and to collaborate with Dave and Christy. It's a ton of fun, and I always learn something when I'm here, and I'm excited to be back. So we appreciate you guys helping work with us to facilitate this.
Yeah, absolutely. Absolutely. Yeah, Eddie, my wife is also on like day 35, and nothing makes you feel more inept as a pulmonologist than just say post-viral cough can last for 8 to 12 weeks. Nothing we can do about it. Yeah.
I bet she loves that.
Yeah. Yeah, exactly. Exactly. So as Eddie and Todd said, they really helped dive into these trials. Their discussion of Cape Cod about steroids for pneumonia is one that I like send out and give to residents and learners to say, hey, you should understand this trial. And so why don't you listen to this? They do a really nice in-depth discussion, but they've done a ton of them. They've also recently published their own work, the ACORN trial in JAMA, looking at Cefepime versus Piperacillin-Tazobactam or Zosyn for hospitalized adults. I don't know how you guys find the time to both do this and put out this like high quality literature, but it's awesome. The trial has been fascinating. I'm sure you guys have seen it's been spurring a lot of discussion online, and I'm sure in medicine and critical care departments and journal clubs across the country. So we thought that if we're having a crossover event, we might as well highlight some of the work you did and dive into this interesting article.
Yeah, no, it's really great. We want to, on our podcast, we want to try to stay away too much from work that Todd and I participate in, because we don't want to like make it seem like it's all self-promotion. So when you guys approached us about a crossover event and about the ACORN trial, we were really excited to really give us an opportunity to talk about this, because we're excited about it, clearly.
Yeah, we are too. We were so excited that it happened to come out, and we happened to get this episode together. And really looking forward to a discussion today from the both of you. Just as a quick reminder, the podcast is not meant to be used for medical advice, and the views we express today do not reflect the opinions or policies of our respective employers. There aren't any specific cases today, but if we discuss any patient examples, we will make sure that they're HIPAA compliant. So before we dive into some questions, great job and kudos on a great trial acronym. And Eddie, I hear there's a story behind this, and hoping you can share that with us today.
Yeah, so for the PulmPEEPers, Todd and I, on our podcast, we grade trial acronyms as just lighthearted and fun on a scale of 1 to 10. And I have been pretty harsh on a lot of trial acronyms. And so ACORN is antibiotic choice on renal outcomes, where the N in ACORN comes from the middle of renal. So that's okay, pretty good acronym, I would say. I would give myself in the 7-ish out of 10 range, but it was better. So originally the acronym was antibiotic choice on renal and neurologic outcomes. So the N came from neuro. But at one point during the development of the trial, we decided to drop neurologic outcomes from co-primaries to a key secondary. And so the title of the project had to change as well. So it still worked. It's still pretty good, but it was almost perfect, man. It was almost perfect.
I tried to push forward ACORO, but he didn't like ACORO as much. We kept it as ACORN. The one downside, of course, Eddie, is that people don't think of kidneys when we think of acorns.
Maybe they will now.
Maybe it'll be the new name. Yeah, you guys. Yeah, Cora doesn't roll off the tongue just as much. Yeah, you were forced to downgrade in the sake of good science. Yeah, you didn't want to have your secondary outcome there.
I really wanted the acronym.
I will say this. Some people ask us occasionally, how do you guys do trials of great stuff? And how do you come up with topics for your trials? And honestly, people, I think at times think we're like these brilliant people sitting in a room, and it's nothing like that. What it is Eddie and I, or people in our group will say, what did we argue about on rounds this morning? And what do we argue about? Because we don't really know all the information that we need to know about those topics. And of course, and this is a little bit of the background, but of course, we at our institution spend a lot of time arguing about broad spectrum gram-negative coverage. And maybe we shouldn't use Pip-Tazo. Maybe we should use Cefepime. Those patients RAS -3. Maybe we shouldn't use Cefepime. And honestly, Eddie can talk if he came to this topic in a different way. But this is how I came to this topic. Was we argue about this a lot on rounds, and nobody can tell me if there's a right answer. So maybe we should do a study and get some data on it.
Yeah, I think that's probably the best way to get a study is we should know the answer to this, but we don't have one. So how are we going to get it? And very applicable, which we'll talk about, very bedside applicable. Now, that's a perfect intro. So just as a brief background for anyone who doesn't know, I'm sure a lot of our listeners do, Cefepime is a common fourth-generation cephalosporin. Zosyn or Pip-Tazo, Piperacillin-Tazobactam, is a beta-lactam and beta-lactamase inhibitor. Beta-lactamase being the most common resistant mechanism in gram-negative microbes. They're used for empiric coverage for gram-negatives for patients with sepsis or pneumonia or those at risk for Pseudomonas. And the latest IDSA ATS guidelines for what is a risk factor for Pseudomonas includes in prior infection or colonization with Pseudomonas, a hospitalization, and IV antibiotics in the last 90 days, underlying structural lung disease like bronchiectasis or cystic fibrosis, which puts you at risk. Or if you are severely ill and you have pneumonia or sepsis, if your local antibiogram shows that you have greater than 10% multi-drug resistance or high prevalence of Pseudomonas, you may actually need one of these drugs and another second agent, which is part of their recommendations as well. And then a general category for immunocompromised. And then, of course, we always think about severity of illness. You have a lower threshold to use broad spectrum coverage for somebody who's in septic shock and in the ICU, although this study included people both in the ICU and outside. Both these drugs have pretty similar coverage. Cefepime is often quoted as covering fewer gram-negative anaerobes, Bacteroides and abdominal sources being the most common. And so sometimes if there's a high suspicion for anaerobes, it's combined with Flagyl as the most common add-on drug. But otherwise, they cover Pseudomonas and they cover gram-negatives in a pretty similar fashion. And so then the choice is often, as Todd said, just throw up your hands or hospital dependent or institution dependent or cultural. And so this trial was trying to get at making that choice a little bit more nuanced.
Thanks for reviewing that. And I think most of us listening today have either ordered it or picked one or the other antibiotics based on an order set that may be available. And as you discussed, Firth, the efficacy and coverage is very similar between the two. And some of the choice of which drug is used up front can be cultural or institutional, as you mentioned. But given the similar efficacy, we also have to consider what adverse effects may be known. Eddie, can you tell us a little bit more about the main adverse effects of concern and what was known or perhaps not known before the study came out?
Yeah, no, this ties a little bit into what Todd was saying about how did I come across this question. When I started as an intern, for everything for empiric broad spectrum antibiotics was Wang and Zosyn or Wang and Piperacillin-Tazobactam. And then all of a sudden there was a lot of retrospective observational studies associating Pip-Tazo, particularly Wang and Pip-Tazo in combination, with risks of kidney injury. And at our institution, when I was training, I saw this shift, this wholesale switch from using Pip-Tazo to using Cefepime. And then all of a sudden, we started to see more and more patients who, of course, we see a lot of patients with altered mental status in coma in our ICU. And now all of a sudden we were getting EEGs, and our neurology colleagues were saying, well, the EEG read says stop the cefepime. And then we got introduced to this, probably a side effect that probably exists, but probably is also pretty rare, of cefepime neurotoxicity, which can span a spectrum of presentation ranging from coma to agitation. But we were in the ICU at least worried about some of the coma perspective of it. So we have some retrospective observational data, which has limitations by confounding, and some publication bias that says, well, you can't use Pip/Tazo because of AKI. And now all of a sudden we have case reports and case series and anecdotal local evidence saying, well, can't use cefepime either. And so now we're stuck in the middle. And should we use meropenem as our empiric gram spectrum antibiotic, carbapenem? And every ID steward who's listening to this podcast, they just puckered a little bit.
Yeah.
That's how we came about with the idea for this study.
Thanks so much, Eddie. I know. I feel like everyone's not bringing out the meropenem right now. It's too early. But I think,
Monty, I will add that these are big enough potential adverse effects that the FDA has weighed in on both of them. So there's actual warnings on Pip/Tazo for renal failure and warnings on cefepime for neurotoxicity, especially in patients that have renal failure and dose adjustment and that sort of stuff. And so it's not, we looked into this because the first question always is this a problem at our institution only and everybody else has this figured out? Or is this actually something that's more widespread? And I think, and people can provide feedback if they have differently, but I think this was pretty widespread where people struggled with this because there are FDA labels saying you should be concerned about maybe potentially some renal failure and or neurotoxicity with one or the other of these drugs. And I think that makes it even more applicable to our clinical practice.
Yeah, this really was like clinically pervasive, at least the thought. So I think cefepime neurotoxicity is probably not that common, but we had a time that I went on service, and we came on to service of 10 patients existing. And if you look through their charts, 5 of them mentioned cefepime neurotoxicity or the concern for cefepime neurotoxicity. And some of them switched to meropenem as a result of that concern, because at that time we weren't using Pip/Tazo as frequently. So it was really clinically pervasive, and it was impacting our clinical care. So
Eddie and I had a couple laughs during the ACORN trial where we had our neurologists read an EEG as consistent with cefepime neurotoxicity in a patient that was in the Pip/Tazo arm and not even getting cefepime. And Eddie would be like, they're not even getting cefepime.
Yeah.
What is going on here?
Yeah.
But I think you both bring up such great points. And I feel like I spent a lot of my time in our oncology ICU, so coming in with a lot of neutropenic fevers. So I personally would tend to go cefepime route versus vancomycin and vancomycin, but I think we'll go through some of the implications of the study and whether or not my practice pattern will change. But Todd, I'm curious for you, prior to the ACORN study results being out, how did you make the choice between the two agents for gram-negative as well as anti-pseudomonal coverage?
Yeah, it's a great question. And actually, we did ID Journal Club yesterday at our institution. And at the end, and it was the ACORN trial. And at the end of it, the ID folks asked me, they said, Todd, how has this changed your practice? And I admitted, it was the first time I really thought about truly my practice. I had admitted that me initially making the decision of Pip/Tazo versus cefepime doesn't really happen that often because I work at an institution where I have trainees under me and they make that decision. And I'm a guy when I'm on service where I think there's some art in medicine. And if you're doing something that's reasonable and I don't know that it's wrong, I'm like, okay, maybe I would have done that differently, but I'm not going to just change just because my name is on the door and I would think that I would do it differently. So the initial decision, I didn't make very often, I think because I'm old and cefepime actually, I don't think was even a drug when I was training in residency. I think I tend to use more Pip/Tazo, but oftentimes the house staff were like, we started this patient on cefepime and vanc, and I would be like, that's reasonable. Then where the decision really happened was if I thought I needed to change the drug. So if the patient got renal failure, I would say, I know that it may not be the Pip/Tazo, but we should just change off of it just to make sure. Or that patient that has neuro findings or is in a coma and I don't know why, I'm like, just get rid of the cefepime. Then we don't have to worry about it. And so that was where my decision on these came in. And it really was based off of did I think there might be any possibility at all of it being an adverse event? And then if the answer to that was yes, changing off of it.
Yeah, that totally makes sense. And yeah, totally right. Very rarely am I making the upfront. In fact, recently I was working in ICU where I didn't have a resident and I had to adjust a Vanc dosing. And I was like, oh, I remember how to do this. It took me a while to recover that skill set. But yeah, but then you offer something on rounds because you're discussing it and you're like, oh, this could be interesting. And it adds to our data set now. So before we go into ACORN specifically, I think it's important to understand the trial design, which we'll talk about more. And this is a pragmatic trial design, which I know you at your institution have done quite often. We had Matt Semler on the show previously talking about pragmatic trial design in the context of ARDS. But Todd, for our listeners who may not be as familiar, can you walk us through what a pragmatic design trial is and then the advantages of it or any disadvantages that come up that we should consider?
Yeah, so first, a little bit of a joke that runs around in our group, which is that lots of people use the term pragmatic to what we term crappy trials. And they didn't do something, they didn't collect some data that everybody wants and they just didn't collect it, or they have a bunch of missing data or those sorts of things. And they say, oh, yeah, it was a pragmatic trial. And we go, no, that's not a pragmatic trial, right? That's just not good study design and not good study conduct. So for us, pragmatic means that you're trying to do it with as little research specific interventions as possible. So the stuff that you're studying is being used in clinical practice and it's part of people's clinical practice. And the outcomes, that the way you're doing the interventions are as they're implemented in clinical practice. The inclusion exclusion criteria, in an ideal world, there would be inclusion is everybody and exclusion is nobody. And you try and get as close to that as you possibly can to make it as generalizable to all the patients that we take care of. And then the data that we're collecting are data that are hopefully already available as part of the patient's medical record. So we're not trying to come up with some special outcome that requires 57 blood draws and special lab procedures and that sort of stuff. We're trying to use data as our outcomes that are already collected. Sometimes that stuff, in our trials at least, sometimes those are data that are already in an electronic medical record, but we also use other data streams. For example, our infection control folks have a lot of data that aren't specifically, I guess they're in the medical record, but they're not easily extractable from the medical record. And we will use them for drug-resistant data that we have to report to authorities anyway. And so we have already collected them in our healthcare system. And so for us, that's the pragmatic part of it, is to try and make it as similar to clinical practice and encompass as much of clinical practice as we possibly can.
Thanks, Todd, for sharing that. And I think really a great setup for the trial that you and Eddie did, obviously with other team members as well. But Eddie, with that background that Todd just provided, how was the ACORN trial set up to answer the question about Cefepime versus Piperacillin-Tazobactam?
Yeah, so I think there's a couple of things that go right into what Todd was saying about this trial being pragmatic. So the first part of it was we wanted to try to match our clinicians' workflow. So at the very beginning, if a patient met the inclusion criteria, we had our EHR set up to have an interruptive alert that said, hey, looks like you're ordering Cefepime or Pip/Tazo. Do you think this patient would be reasonable for enrollment in the ACORN trial, which just assigns that choice randomly? If so, just hit accept, and it'll lead you to an order set that tells you which arm that got randomized to. So so one of my other hats is informatics. And after the ACORN trial finished, I had a bunch of providers come up to me and say, we really miss the interruptive alert for the ACORN trial, because it was easy for them to not make the decision and just let it go up to the randomization. And that was the first time, I think, in informatics history where someone said, hey, we really miss that pop-up.
Yeah. Yeah. You don't often hear that with BPAs or anything like that.
No, never. It wasn't just that we were okay with the BPAs, we miss it. So I think that just shows us that we matched our workflow pretty well. That's for the enrollment. On the back end, we ended up using outcomes that were using things that were normally gotten in the EHR. So our primary outcome was AKI on an ordinal scale, where 0 was no AKI. Stages 1, 2, and 3 were stages 1, 2, and 3 for the KDIGO AKI creatinine criteria. And then we thought that death was worse than any stage of AKI, so that was assigned an ordinal level of 4. But for those criteria, they just use creatinine. And that's something that you could argue about choosing wisely. We should probably get less, but the unfortunate truth is that we get a lot of creatinines. And so we had a pretty good gauge of creatinine levels as the hospitalization proceeded. And then we also looked at major adverse kidney events within 14 days, which is a composite of doubling of your baseline creatinine, which we had, new renal replacement therapy, where if you get dialysis in the hospital, that's recorded in the flow sheets, or if they died in the hospital, which is recorded. And then from a neurologic perspective, we looked at delirium and coma-free days, which we defined delirium as having a positive assessment on the CAM ICU and coma as a -4, -5 on the RASS scale. And these are routine nursing assessments. So for all of our patients in the hospital, RASS is recorded every 12 hours. And so it's not something that we had to have like a specialized research nurse to go around and collect.
I will add that, and you had asked a little bit about this, Dave, in the downsides of pragmatic trials, because we're trying to enroll as many patients as we can and be as generalizable as we can in clinical practice, we also have a little bit less of the boundaries of what clinicians can do. And what that ends up with, and people have asked us a lot about this, is you end up with a proportion of patients where after a couple days, the clinician says, I know this patient was randomized to X, but I really want them to have Y. And we don't know exactly why that may be in every single patient, but in the pragmatic way of doing these trials, we let that happen because that's part of clinical practice. It makes it harder for us to see a signal, and it makes it a little harder for us to sometimes truly test the hypothesis that we're trying. But the trade-off is that we get a broader population and more patients enrolled because we don't have inclusion-exclusion criteria. Eddie talked about the pop-up at the beginning. There also was a pop-up when they would change off of the antibiotic that would ask them why they were changing off of the antibiotic. So we had some data. It wasn't just if they changed to the other one. Anytime they discontinued it, and it may be they would say therapy's finished. We don't think we need this anymore, and we're just stopping it. Perfect. But there was another pop-up. I suspect that they didn't tell you that they really missed that pop-up, though, Eddie.
No one mentioned anything, so I'm going to say that they missed it until otherwise.
Yeah, that's really interesting, and we'll get into it with your results. But I love like some of the pre-specified sensitivity analyses you had to address that question of like, oh, how long were they on the trial intervention, which is just a little less strict than you would have in a typical randomized trial. But then it's very real life. This is how we take care of patients, and so it helps answer those questions. To that end, I really love the pragmatic trial design idea, and I think more institutions should do it. And I think that some of those institutions don't understand exactly how it gets integrated into practice. So it's great to hear about the BPA. Sounds like the clinicians really liked it. I'm curious if there were any other challenges as you want to get this up and running with like pharmacy, infection control, ID. Do people put up a big fight to doing something on a broad scope like this? Or is your institution pretty used to these types of trials at this point?
I think I could start there. I think part of it is that our institution is used to doing these types of trials, but part of it also is, I think, that people recognize the question and also experience the frustration that we described earlier in the podcast. And so people were interested in doing the work to get this question answered. But also, I think something that doesn't get a lot of glory when you're talking about trials is the setup and the buy-in from all of the stakeholders. So we went around to our divisions of hospitalist medicine, ID, surgery, pharmacy, emergency medicine, critical care, and we gave presentations to say, hey, this is the problem we see. Do you see this problem too? Okay, great. This is the trial we're doing, and this is how it's going to work. So we had a lot of buy-in from the get-go or really close to after we started.
Yeah, I think a big part of it is engagement from key stakeholders on the front end. Mm-hmm. And the ID folks, as you talked about, our infectious disease colleagues were key stakeholders, and they were agreeable to testing this because they said this is a real question. We need to know the answer. And so they were on board. And we tried to do that as much as we can on the front end. He's underselling it a little bit. He spent a lot of time in the early parts of the trial where somebody would either say this patient's excluded, and you had an exclusion that essentially was, I know the right answer, right? Eddie knows a lot of the guidelines now for a lot of non-critical care
Yeah.
infections, because he would go look up the guidelines and say, how do we know that this is the right answer? There's no right answer here. Or the number of times that he would call me and say, but the guideline says you can use either Cefepime or Pip-Tazo, right?
Yeah.
Why do they think that only one of those is an option? And also, and this is important too when you do pragmatic trials, because remember, in these trials, the person essentially enrolling the patient and doing the intervention is the clinician. It's not a research personnel. And so getting them to understand that the worst thing you can possibly do is randomize a patient, see what they're randomized to, and then say, no, I don't like that, and change them to something else. We're better off if you truly think in your mind this patient needs X, to just say, sorry, this patient's not eligible and we're not going to randomize this patient. That means it's not quite as generalizable as we would like, but it doesn't hurt the internal validity of or bias the internal validity of the trial. And Eddie and I and other team members spent a reasonable amount of time getting people to recognize that, so that we have as high fidelity and internal validity in the trial as we could.
Yeah. Yeah. That education and outreach sounds so important. I feel like I was saying in medicine that we're all skeptics in medicine, except of our own knowledge. And so everybody's skeptical about a change, except for things that they quote unquote know. And so getting them to buy in, I'm sure, was extremely helpful.
Yeah, it's a key part for sure.
Yes, I feel like y'all did so much work to get the trial up and going, and now we'll say the trial's in place. And Furf and I have talked before on PulmPEEPs and other episodes about the first step with the trials to see if the randomization worked well. And you alluded to some of this, Todd, as well as if the intervention was received by patients as it was intended. Todd, can you share a little bit of what did the cohorts end up looking like, and how did the randomized interventions turn out?
Yeah, so I think Eddie may think differently, so he can disagree if he wants to. But I think we were pretty happy with the patients that we had enrolled. It was a pretty broad population, and Eddie and I are home critical care people, obviously. But if you look at this, the vast majority of the patients actually don't get admitted to an ICU. They actually are they have to be admitted to the hospital. That's obviously one of the inclusion criteria, but they aren't admitted to the ICU. And so we knew that was going to happen, but didn't know exactly how much that was going to happen. And it's about 20%, 20 to 25% of the patients that end up being admitted to an ICU, and the others are not admitted to the ICU. And then we spent a lot of time talking about the kind of elephant in the room here is, should we enroll patients that already have renal failure? Why? Maybe we should exclude them because they already have renal failure. But in talking with all of our colleagues, both our nephrology colleagues and our infectious disease colleagues, and I think this is still largely true, it was really unknown what the mechanism of causing renal failure was in Pip-Tazo, if it caused it, and whether that was it causes renal failure in patients who don't have renal failure, or whether it was the patient that's starting to get a little bit of renal failure. Pip-Tazo just makes that way worse. And if you don't have any renal failure, Pip-Tazo's okay in you. And similarly with neurotoxicity and Cefepime. And so we decided that we weren't going to exclude patients that were in coma or patients that already had baseline renal dysfunction at enrollment. And you can see, if you look at table 1, there are patients. It's 10% of patients have stage 1 renal failure, 10% have stage 2 renal failure, et cetera, et cetera. So you end up with a reasonable number of patients. Let me see if I can do some quick math here. It's 30% overall, I think, that had renal failure at baseline coming in. And then the big subgroup that we wanted to make sure that we caught. And in fact, our DSMB was helpful in this regard, because at the interim, they said, you guys are doing such a great job of enrolling, and you have such a high use of co-administration of vancomycin that we think you should actually enroll even more to make sure that you have enough vancomycin patients that you can look at it as a subgroup. Because in the literature, at least with Pip-Tazo, there was this question of maybe it's not Pip-Tazo alone. Maybe it's Pip-Tazo plus Vanc that's actually what's causing the problem. And we were excited about the fact that almost 80% of the patients essentially in the trial got co-administration of vancomycin with their broad gram-negative coverage, whether it was Cefepime or Pip-Tazo. Eddie, anything to add on that?
No, I think, Todd, you covered it well. Sometimes Todd likes to use a lot of words where a few words do trick. And so basically our DSMB said that we need a power for our co-administration of vancomycin subgroup. And though it's a subgroup, and you might say, oh, that's hypothesis generating, and like a normal trial, we were powered for that subgroup, which I think is really something to highlight.
That's great.
Eddie,
Todd, we're here for
Eddie, we're gonna have some listener that's gonna count my number of words and your number of words, and then report back to us who was more verbose.
Great. I welcome that.
Yeah, we're here for the loquaciousness, Todd. You can bring it to PulmPEEPs if you want. So that's great. So we have some comparable groups. We have this high co-administration of vancomycin, which really helps us answer our true clinical question. As Todd alluded to earlier, you guys had some crossover, but median course of antibiotics is 3 days, pretty solid, and a large cohort that had a longer course. I'll take a minute to say, and I mentioned it before too, I just love the pre-specified sensitivity analyses that you said. You anticipated this problem and said, we're going to do an analysis that just looks at people with the longer course. In addition to the total analysis, we're going to look at an intention to treat analysis and per protocol analysis. Really love all of that. I think sensitivity analyses like that really add to the validity of these findings. But before talking more about it, Eddie, I was just hoping you can walk us through the primary and secondary outcomes between the two cohorts.
Yeah, no, just a point on the sensitivity analyses. It's the great thing about peer review for everybody, but like the bane of the author's existence is these peer reviewers are so smart and they have all these questions. And so we had a lot of great sensitivity analyses that we pre-specified. But then after the fact, based off of what our reviewers had mentioned, we had just so many sensitivity analyses. So I really do think that in the end, we ended up slicing the data in every way to try to make sure that our findings were robust. So
it's not a universal, but it's pretty well established that our group in general doesn't do a ton of post hoc sensitivity analyses. We try and think of them ahead of time, and then we do them, and then we say, okay, this is what we thought of ahead of time, and that's what we have. So in the manuscript, for example, if you see something that says post hoc, it means that it was a smart reviewer that said, hey, what about this? And we said, oh, we can do that analysis to answer that question. That's a really good question. And then we end up doing the analysis, and it's not pre-specified because we weren't smart enough to think of it, but we did it because the reviewer was smart enough to think of it.
Yeah, that's how you end up with I think it's 5 pages or 6 pages long, one of the tables in the supplement. That's how you end up with that. Who's counting, though?
Yeah, right.
For our primary outcome as a review, we used AKI on an ordinal scale. 0 is no AKI. 1, 2, and 3 are stage 1, 2, and 3 AKI. 4 is death. And we found between the groups, it was about 75-ish% patients never experienced a new or worsening AKI by day 14. And I won't read every single outcome on each group, but we ended up finding that there's no difference between the groups, Cefepime or Pip-Tazo, and there was an odds ratio of 0.95 and a 95% confidence interval that spans 0.80 to 1.13. No significant difference in AKI. This bore true in all of our subgroups in the effect modification. I think that's figure 3 in the table, the forest plot. We looked at kidney injury, so we said, hey, we might not necessarily care about creatinine elevations. What about like clinically important outcomes? That's why we did the major adverse kidney events by day 14. And we similarly found no difference between the groups. There was an absolute difference of 1.4% and a confidence interval that spanned 0. So negative 1% to 3.8%. The other secondary outcome that we said was a key secondary outcome for us was the delirium and coma free days by day 14. And this we actually did find a difference. There was the odds ratio here was 0.79 with a confidence interval that ranged from 0.65 to 0.95. So it didn't cross 1 there. And so this is actually a little bit confusing. And Todd freely admits that he still sometimes gets confused. What this means, so an odds ratio of less than 1 here means that there were more days free of delirium and coma with Pip-Tazo. So that means if you take out some of the double negatives and otherwise, that we saw more delirium and coma with the Cefepime group, which is congruent with what the hypothesis would be.
Yeah, Eddie's just making fun of me because as we were doing these, the which group is doing better and might be favored flips across 1 depending on what the actual outcome is.
Right.
And so I always asking, wait a minute, who does this favor again? What does this result favor again? How does this work?
It's just that more usually is like, oh, you want more of something, or less, like you'd like less mortality, less AKI, less this. But for this outcome, you want more days free of whatever you're talking about, more days free of the ventilator, more days free of delirium and coma. So the directionality of our odds ratios flip. which makes it hard.
And I like on your forest plots, it tells us very conveniently favors Cefepime, favors Pip-Tazo, which really helps.
That was intentional.
Yeah. Yeah. Speaking of those forest plots, I'm just curious if there were any subgroups that popped out to you guys that made you think a little bit about certain patient populations. I noticed in the non-septic subgroup, it still wasn't significant that we had to worry about kidney injury, but the lines look like it trended in that direction. Any subgroups that you think it was important for the readers to take note of?
I think we talked about Vank. Obviously, we were really concerned about the vancomycin subgroup. I think some of our colleagues, some of our surgery colleagues were very interested in the surgery subgroup as opposed to the medical subgroup. And then I think and we also talked about the different stages of baseline kidney dysfunction that we thought might help better explain whether this is a de novo injury if it's happening versus a worsening of something that was already present. And then as it's come out, people have started asking questions. One of them, as you brought up, is what about the no sepsis group? This is a hard group for me because we adjudicated sepsis on the back end, but ultimately to come in, somebody thought you needed antibiotics. And so it's not like the doc on the front end thought you didn't need antibiotics, but was giving them anyway. And so how do you implement that into practice? And I still don't know exactly that I know the answer of how to implement that in practice. And then one thing that you won't see on here that has been a question is, what about patients that we're really worried about the anaerobic coverage in? As you said, Dave, earlier, the Cefepime has less robust anaerobic coverage. And in fact, and we don't know the exact numbers, we're getting them from the medical record, but in a proportion of the patients in the Cefepime group, they also got Flagyl, because if there was a big concern for potential anaerobes, then Cefepime may not be appropriate enough coverage, and Cefepime and Flagyl may be needed. And so there's some question about what about potential anaerobic activity, and in the patients who you're worried about anaerobes in, or grew anaerobes in, or got anaerobic coverage with Flagyl added to Cefepime, what does the effect look like in that population? And that's not in this report. That's, I think, to be coming down the pipeline.
Yeah. I wanted to talk about that specifically. I think that data out of Michigan by Dr. Chandaraj and Dr. Dixon looking at anaerobic exposure in VAT patients, and like even one dose of anaerobes is seemingly what they looked at, has this difference in mortality, which is pretty fascinating, thinking about the effects on the microbiome. So it's interesting that you guys are already thinking about that and you have some baseline data. Is that next on the Pragmatic trial design docket, or are you looking back at the data you already have to try to get some answers?
I mean, I think like directly next, we're going to look back at the data we have, but I don't know. It is really fascinating. That paper is really interesting in the way that they combined some translational work and then some work from their EHR into one really nice paper. It is something that's provocative and we want to look at. And Dr. Dixon has reached out to us asking that question specifically.
Cool.
That's great. A lot of things to look forward to. I think given this, Furf and I think this is such a great study question that y'all both thought of. Great study design. And from the results, it's pretty clear about the no impact on kidney injury, but the slight neurotoxicity associated with Cefepime, which was done in a real world clinical setting. And I think I have two questions for you, and Todd and Eddie would love your comments on them. Now, Todd, when you're back in the MICU, you're on rounds. How are you gonna support this data to the decisions that you're making and what you're teaching with house staff? And interested just to hear from either of you, has the results changed your personal practice or the general institutional practice at your respective institutions?
Yeah, I think a couple answers there. One is that for me in clinical practice, I think it means I can be more comfortable not changing somebody's Pip-Tazo if the patient's starting to develop some renal failure, especially if I think Pip-Tazo really is the best choice for that patient, and not necessarily say, okay, maybe it's causing the renal failure, I don't know, let's do something else. I can say, no, I really think this patient would benefit from Pip-Tazo. We should continue it because it's unlikely that its renal failure is directly attributable to the Pip-Tazo. The Cefepime neurotoxicity, Eddie will laugh about this, but we in our group argued about what does this mean? It's a signal, it's statistically significant. When you look at the mean difference in delirium-free days, it's not very big, but it also doesn't affect very many people. And so maybe it's bigger in the people that it does affect. And the neurotoxicity are hard data to get. We have it in a pretty ungranular way. We don't have very good details on it. And I think it's going to be another one of the more detailed explorations that we do is we're going to try and look at those populations a little bit more and find out who are the patients that it really affects. Because as we talked about at the beginning, the black box warning is specifically for patients that have renal dysfunction and dose adjustment. And we have great pharmacists at our institution that do dose adjustments. And so I don't think we have a lot of patients that we're getting an inappropriate dose, but maybe even with an appropriate dose, renal dysfunction is still a risk factor for getting it. And I think that would be helpful. And then at our institution, we actually have a pop-up at, is it 48 or 72 hours, Eddie, that the pop-up is?
It's 72.
At 72 hours that essentially says, hey, this patient's still on Pip/Tazo and Vanc, and it might cause renal failure. You should switch them off of that. And we're working actually to try and get rid of the pop-up within our clinical system because we think it's probably not the most evidence-based pop-up based off of these new data and the evidence that we have. And then the last part of this that is, I think, a bigger hurdle for us, but we have been charged by our institution. Our institution, when we do these trials, wants us to implement them both in our practice locally, but also disseminate them and implement them across it. And they've asked us, how are you going to address these findings with the FDA and with the FDA's warnings and that sort of stuff? And we're still working on trying to navigate that terrain to get engagement with the FDA and at least some better understanding of how does this affect the black box warnings that are on these medicines and what we should broadly disseminate as knowledge that the bedside clinicians should know.
Yeah, no, I think Todd covered it. I've been on
too many words, right, Eddie?
Too many. A few words do trick, Todd.
Yeah.
I've been on service a couple of times since this came out, which at the time of recording has only been a month, so I'll let that sink in for a second. But I don't know if some of this is like biased because, obviously everyone at our institution who's working with me as attending knows about the ACORN trial, but I've seen a lot more Pip/Tazo being used since the ACORN trial came out. It's been closer to 50-50, whereas before it was really a lot of Cefepime. I think that was the predominant and a broad spectrum antibiotic that we use for gram-negative coverage. But I've seen both, and for me, like, it's not me saying, oh, this patient's on Cefepime, we need to switch him to Pip/Tazo. I don't think that the data supports that. I think that's what some people think that I might say, or my conclusion. I don't think that at all. But I do think that with this signal for the neurotoxicity, the delirium and coma with Cefepime, it's something that I look at a little bit more. So if my patient is coming in with baseline renal dysfunction or baseline coma already, and they might have a risk factor for that or exacerbation of that I will think a little bit harder about switching from Cefepime to Pip/Tazo. It's really, I think, that specific case, at least that I've come across in my practice.
Monty, can I use this opportunity to ask you a question?
Please.
So interestingly, as we were doing the trial, Eddie, you have to make sure that I'm clear on this because I always get it confused. Our BMT colleagues told us that they didn't want to enroll their patients because there were data that Cefapime's better. Is that right, Eddie?
I think our practice has been Cefepime is better, but I think there was data suggesting that there's harm with Cefepime, actually.
Oh, is that right? In that population. Yeah. I can never remember which side of it was. So we don't have great It's not like we're a BMT hospital and we would have had 100% BMT patients anyway, but we didn't have as great of representation of our BMT population as we would have hoped because there was this hesitation from them. And so you commented about working in an onc unit, and I wonder, with relatively less representation of oncology patients in the trial, how do you think this generalizes, and does it change what you think you'll do, specifically in that environment, not when you're in the general medical ICU, but when you're in the onc ICU?
Yeah, no, I think that's a great question. And what my takeaway too, and I think you mentioned some of this, Todd, right? And I think the thing is, it's not necessarily switching from one antibiotic to another once it's already started. But I think my practice patterns will change if someone is coming in with an AKI already, that the ACORN trial will show that it's okay to use and if that's indicated for this patient. So I would feel more comfortable starting that at the onset based off of these results. And then I think the Cefepime neurotoxicity, I don't know what everyone thinks. I feel like when you say that, sometimes some people just put their hands up and was like, oh, is that true? Is that not true? But I think it is. And I think we anecdotally showed stopping Cefepime on someone, their mental status did improve over time. I think that's an important thing to consider. I feel as our neutropenic fever order set, Cefepime is the top medication medication there. Myself, our house staff may actually just pick that because it's the first one they see, but I think that there needs to be more education about the two antibiotics when choosing and making sure we're doing the best thing for patients.
Yeah, it's great. We know because we heard from some folks that, and we're not in the ID world, so I don't think we necessarily had our eyes open to this, but we heard that there are Cefepime hospitals and there are Pip/Tazo hospitals, and they really are driven by just dogma that our hospital is going to be Cefepime or our hospital is going to be Pip/Tazo. And we're intrigued to continue to have discussions with them and have follow up with them to see how these results might change, whether they continue to be a Cefepime hospital. And the reason I bring that up is because I thought of that when you said we have a bunch of order sets that essentially direct you to Cefepime. You may not think you're a Cefepime hospital, but if you look at your order sets and most of them are Cefepime, you might qualify as a Cefepime or a vice versa for Pip/Tazo hospital. And it'll be, I think, very interesting to see if and how those practices change based off of these results.
Yeah. When I moved from residency to fellowship, it was a switch in Cefepime to Zosyn. I think we were in Zosyn when I was in residency and Cefepime fellowship. And then when I would suggest Pip/Tazo, people would say, like, oh, do we really need to escalate their treatment? And it was this just totally cultural thought that Pip/Tazo is actually like a higher rung coverage than Cefepime, when really their spectrum of efficacy, aside from anaerobes, is essentially the same. You're using it for the same indication. So that cultural influence really makes
I thought you were going to say when you suggested Pip/Tazo, people were like, are you the devil? What is wrong?
Yeah, right.
People are like, they have hard thoughts about these things, right?
Right.
You know, they're like, what? You want to kill the patient? What are you doing?
Yeah, they only say that to me when I suggest Avacaz or Zerbaxa or something like that.
At my institution, they think that to me when I suggest an aminoglycoside. Because
Yeah.
they don't use an aminoglycoside at all. And I'm like, what about an aminoglycoside? And then you get that look of, you want this patient to die, Dr.
Yeah.
What's going on? You're like, wait, no, it's a real antibiotic. People use it.
Yeah, and in fact, in the guidelines for double coverage.
Yeah.
This was a great discussion. Thank you, guys. I think a lot of our listeners will learn from the ACORN trial. I know a lot of people are still discussing it, and hopefully they have great takeaways. We like to wrap up the episode with just one either learning point or takeaway point or just one final word. Mine is I actually just really loved your comment, Eddie, about the interruptive alerts and how people find that helpful. I think they are so demonized in our healthcare system as something that is to be ignored and just adds extra clicks. But it's cool to hear that in the right context, they can be used for efficacious practice and for research. So I really like that. Christina, anything as a final word?
No, just a really fun time today that I've had. I think just going back to what Todd said at the very beginning, right? This question was stemmed from just being on rounds and not having great evidence to support one recommendation or the other. And just the pragmatic design that was done, it's really just bringing everything to the bedside. So just love that aspect about this.
Eddie?
Why waste time, say lot word when few word do trick, Todd? I don't think I could not just make another plug for informatics. Get to know your local informaticians. We don't bite. We can do a lot of good for you. What Todd was mentioning about, like, oh, you might not realize it, but your order set has Cefepime in it, and that really drives your practice. That's informatics, right? The goal of informatics is for you to not know that they're doing anything, and something like sneaky, like an order set, not sneaky, but something like in an order set, and what kind of presets, what's pre-checked, what shows up to you, how you search for things, and how that comes up. Those are all things we talk about in informatics.
Yeah, I think for me, first of all, once you get the results and you get to talk about the results, it's a ton of fun. And talking to people outside of our group about the results is always a ton of fun. And I love getting other people's takes. So Monty's take of, and I never even thought of this, Monty's take of, in general, when a patient comes in with renal failure, we tend to push towards Cefepime because we don't want to give that patient Pip/Tazo on top of their renal failure. And I think these data suggest that we actually do have a real choice there, and we can choose whichever one we want. And thinking about talking about the trial with smart people that aren't in our group always opens up new thoughts and new ideas and new ways to interpret it. And I think that's the best thing about clinical science and clinical medicine and the overlap, for sure.
Truly. Thanks, everyone, for listening to PulmPEEPs and the Todd-Cast, and we'll all see you at the next episode. Have a good one.